So our plan here is to do limbal relaxing incisions at 145 degrees. So our toric axis marker has been set for that. And there's our 145 degree axis. Now that means that I don't want to put the side port incision near where the limbal relaxing incisions would be for obvious reasons. So I'm going to go significantly distal from that spot. And now using my index finger to fixate the globe, I'll make our primary 2.4 millimeter clear corneal incision. And now injecting the intraocular lidocaine. And you can see the Bell's phenomenon in response to a little bit of stinging. Now there are two lights right there in front of you, Peter. See if you can look right at those two lights. Very good. So fill the anterior chamber with viscoat, and beneath that we'll put some Provisc. I'm injecting here in case there's a bubble, which there is. And there's the Provisc, and there's an incision made right in the anterior capsule. And so I'm going to use the spatula to position the globe. Wet the cornea, please. And then I'll just grab the capsule here and start to tear. Those first few millimeters of the tear set the stage. Take it right out to the distance from the pupil you want it, and then the rest of the way around, just follow it. So there's our pretty well-centered capsular excess. Now we'll just do hydrodissection. Slip underneath and then lift up, and then inject. And then depress. Same thing on the other side. Some little bubbles were in that syringe, but they're gone now. And now viscodissection. Now this will probably be some considerable consistency to that nucleus. I can kind of tell by the way it behaves. Rigidity will probably be above average. Infusion capacity looks just fine. So we'll put the chopper into that incision, then insert the phaco tip, and then complete insertion of the chopper. Now here I'm going to put the chopper out over the equator. You can see my hand position here. That's not quite the chopping hand position, that's the stabilization hand position. The chopper is not depressed. We'll show you that maneuver when we get to it here in just a moment. So now I've sculpted deeply. You see the red reflex in the middle. And now I kind of steepen the axis of the chopper as I drag it centrally. I call it verticalizing the chopper. Wet the cornea, please. Now that's an impale chop. You can run your video back. Wet the cornea. And denser lenses, I'll tend to do that. So I impale on position 3 and then back out to position, foot pedal position 2. Quadrant removal. And then hold it in foot pedal position 2 while I chop it. So notice that what I did there, I just lifted that fragment up to have good access of the phaco tip to it. I would rather bring fragments to the tip with either flow or the second instrument than chase them with a phaco tip. The phaco tip kept in the center of the eye as much as possible is a desirable technique. And of course, the chopper's behind it while I remove the segments, just in case that posterior capsule wants to come forward because, of course, infusion misdirection syndrome, which I've talked about many times. So now we're ready for cortex removal. So infusion capacity is good on our INA tip. Now I'm going to use the spatula here to protect the posterior capsule because it isn't all that far back. And especially right here, subincisional. I tilt the eye toward me and was able to then get that cortex. Now we'll remove epithelium from under the anterior capsule for 180 degrees. Again, that has two purposes. One, to prevent capsulorhexis contracture, which is quite rare with acrylic IOLs. But also, the second reason is should IOL exchange be required, it'll be much easier to do that for months. Okay, so here goes OVD. Now, you probably saw there's a little cortex there. I'll probably aspirate that cortex after I put the IOL in when I use INA to remove OVD. It's not much, but if I can get to it with the INA tip, I will. Okay, so IOL insertion into the capsular sac. Wet the cornea, please. The view becomes much better while you're injecting an IOL if the cornea is irrigated because the hypotony causes some wrinkles. So I'm actually going to rotate this IOL. You can see that cortex became visible again there as I did that. Yeah. So the next step will be the limbal relaxing incisions. And I'm actually doing penetrating limbal relaxing incisions here. By that I mean I'm going to make some keratome incisions. So I'm going to put the INA tip into the eye, raise IOP, keep that foot pedal in position 1. And now I just move my hand to the other side of the eye. Same thing. It's as if you're making a phaco incision. And these essentially never require hydration. They seal immediately. So now let's get underneath that IOL spatula and wet the cornea. I'm going to remove OVD, and let's see if that little bit of cortex is now accessible. A little tricky to get it. There we go. Center the IOL. And this myopic eye with possible low ocular rigidity, I'm going to leave the OVD in the anterior chamber and I'll irrigate it out after performing stromal hydration. And that way I don't run any risk of losing the chamber because of low ocular rigidity, patient squeezing, whatever. So here we go, irrigating the angle. IOP feels quite normal now. Maybe raise it just a little bit. Good. Okay. So that's our what I call penetrating limbal relaxing incisions. There's about there's about 0.75 diopters there, and I used a 3.2 millimeter keratome for that, somewhere between 0.75 and perhaps a diopter of cylinder there. And we're done.